I'm happy to introduce our first speaker for the day, who is going to talk to us about interventional pulmonology. Let's welcome Dr. Gaetane Michaud, who is a professor in the Departments of Medicine and Cardiothoracic Surgery, and the Section Chief of Interventional Pulmonology here at Perlmutter Cancer Center.
Well, good morning, everybody. It's an absolute pleasure to be here. And actually, more importantly, it's a real pleasure to see a lot of people that I actually know in this audience. So welcome, even though you've already, if I know you, it's because you're already in the system. So I'm glad to see you here. First of all, I want to actually say that you can never actually have a program and just be by yourself. So this is my team. I feel very, very fortunate because we actually have one of the largest and most experienced lung teams in the entire country. So I'm the chief, but as you can see, we actually have a PA, Kristen, who actually does procedures with us in the operating room. We have Vanessa, who's our nurse practitioner who works in the clinic with us. I have 3 partners that actually also do clinic over in the cancer center and see patients and do procedures with me. Dr. Rafek, Dr. Besic, and then at the bottom down here, Dr. Sturman. Most of you will not know Dr. Angel because Dr. Angel is the director of the transplant program. And although he's a trained interventionalist, he only kind of bails us out every once in a while when we need a little help. Many of you will also know Dr. Zook. She's our fellow and she works with us. And all of you who have seen me at the cancer center will know Tracy, and she's fabulous. So what I want to talk to you guys today about are all the many roles that actually a lung doctor can actually play in the care of a patient with lung cancer. And there are many. What's interesting is that there was a consensus statement that came out by my national society back in 2013 that actually looked at what is the impact of actually having a lung doctor as part of a multidisciplinary care team for patients with cancer, with lung cancer in particular. And a lot of the data that I'm going to show you guys today, or a lot of the information actually comes from there as well. So these are the many, many, many hats that we can play. And I'm going to start way up here. So in the lung cancer screening program. So I'm actually the director of the lung cancer screening program here at NYU. Alongside that, there's actually early detection. So it's actually finding cancers early when they're at an earlier stage of disease. And we'll talk a little bit more about that in a couple of seconds. A lot of it also has to do with the fact that most lung patients or lung cancer patients actually have some risk factors that are somewhat modifiable. So we play a big role in education of patients to help them get rid of some of their risk factors and minimize their risk, the impact of the risk factors. Along that, we actually have a very robust smoking cessation program. I tell everybody, if you actually make it into my office, I have every right to stand on my soapbox and tell you why smoking's not a good thing for you. We do a lot of work with respect to diagnosis, and we'll talk about that, as well as staging. We often do restaging after you've actually had a line of treatment. We want to see what happens with that treatment. We're thinking about changing treatment, and we'll talk about that in a couple seconds as well. We do a lot of work with respect to symptom management, so people that actually have manifestations either because the cancer is getting bigger and pushing on things, or the chest is filling with fluid. We'll talk about that a little bit, so we get involved on that side of things. We do a little bit of stuff on risk stratification. So if you're a patient that is actually looking to have surgery, a lot of patients that have lung cancer will also have underlying lung disease. And so we help actually our thoracic surgery colleagues tell them and advise them with respect to how do we minimize your risk and the time around surgery. What can we do to your lungs to make them better so that we reduce your risk of having problems with your lungs after surgery or in around the time of surgery. We also work on this sort of backside over here, which is something that is actually pretty unique to the interventional pulmonary side of things as opposed to just a general lung doctor. And what that means is we do a lot of things that are sort of more on the palliative side. So on symptom control, things like dealing with fluid that can accumulate around the lungs and helping out with people that have bleeding from their lungs from their tumors and also from blockage of the airways. And we'll talk about all of that in a minute. And by the way, this is me in the middle. And this is what my fancy getup was when I walked in here a few minutes ago. I did get changed for you guys because I felt it was pretty inappropriate to come in here in my OR scrubs. So why involve a pulmonary doctor in lung cancer risks? Well, you know what? In all fairness, a lot of the risk factors that can lead to lung cancer, we're sort of on the leading edge of. So when you think about the things that put you at risk for lung cancer, certainly age does. So the older you are, the higher your risk. Smoking, and it really is dependent on the number of cigarettes you smoked per day, the number of years that you smoked, but also timing of your smoking. What we know is that the cigarettes that you smoke, if you smoke 20 years, between 20 and 40, it's actually different than if you smoke 20 years between 60 and 80. And the reason is there's just more time for damage to actually happen, and it increases the risk of lung cancer. So we see these patients, and this is why I actually am on my soapbox all the time. The other thing about smoking is that when we think about on the other side of things, when we think about the treatment side of things, the data would suggest that no matter what kind of treatment that you're going to get for your lung cancer, if you stop smoking, you will do better. So it's really, that smoking piece is very important. Other risk factors, so if you have chronic bronchitis or emphysema, we used to think if you had chronic bronchitis or emphysema that your risk was related to the cigarettes that you smoked to get the COPD. But actually what we know now is independent of how much you smoke, if you have emphysema, your risk is a little bit higher. So we know it's independent. We talk a lot about asbestos. And here in New York City, one of the things that I have come to realize makes a big difference is actually whether or not you've had exposure to 9/11. So there's a lot of stuff that was in that fumes. There's a lot of stuff around ground zero that is actually impacting in New York City. We're really early stages of this, but I think the data is really coming to show us that, because we're seeing a lot of people that are non-smokers that are actually had exposure to ground zero. They lived in the neighborhood. They were breathing the air. They were working on the pile. They were doing different things. Some people were just riding their bikes past there. And they're actually developing lung cancers very young without other risk factors. So I think that that's something that's going to come into play coming forward. If you have lung fibrosis, so scarred lungs, interstitial pulmonary fibrosis, that increases your risk. If you've had lung suppression, if you've gotten radiation for other causes. So for example, people that actually got radiation because they had a lymphoma when they were young, or because they actually had breast cancer. Those are actually increased risk factors because the lung cancer develops in those areas of scar. If you have a family history, so we certainly know that there are increased risk if you actually have a first-degree relative, a parent or a sibling that actually had lung cancer. Prior malignancies, I sort of talked about that a little bit. A lot of that has to do with the treatments that you got for those prior malignancies. And sometimes it's not that you actually develop a lung cancer, but sometimes it's that you develop a recurrence of your cancer in the lungs, because the lungs tend to be one of the favored spaces to actually get metastatic disease. And then we know a lot about nodule characteristics and growth patterns. So we are really good about looking at a nodule if you come in with a nodule and saying, that one really doesn't look so good. I get teased all the time because we sit in a tumor board every Friday morning and we talk about all of our patients, and we look at the imaging and we look at everything else, and I'm always the naysayer. I'm always the one that says, "Ooh, that one looks like a cancer." And they said, "Well, what makes you think it looks like a cancer?" And I'm like, "It just does." And I'm pretty good. I'm pretty reliable, but there's no way to filter that down. I'm batting 1,000 so far, so generally I'm pretty good about it. So, as the director of the screening program, that's my first job. So that's like way early in the time frame. There was a very large study called the National Lung Cancer Screening Trial that was actually published in 2011. What they did is over a 10-year period, they enrolled 54,000, almost 55,000 patients. They were people that were considered at high risk of developing a lung cancer. So by high risk, they were 55 to 77 years. They did not have any symptoms. Therefore, this is why it was truly a screening program, because what makes something screening as opposed to early detection is that screening means that you don't have symptoms. So there's nothing that's bringing you to light or to concern of a doctor. It's just that you have risk factors. And we try to catch things early. The big advantage to screening is if we catch cancer early at a more treatable stage, we have a greater chance of saving your life. So that's what we really want to do. Also, to be considered high risk, you had to have smoked a pack a day for 30 years, and you had to either be still smoking or have quit within the last 15 years. We had to provide what's called shared decision making, which means we sit down and we talk to you face to face. And I do this with all of the patients in the screening program. We talk about the reasons why you should be considering lung cancer screening. We talk about your concerns and reasons why not to screen. So if your risk is really low, then you're just at risk of getting radiation for lung cancer screening. So, because don't forget that nothing comes for free, right? So you do get some radiation exposure by getting lung cancer screening. So we don't do that lightheartedly. That's why we want to look at these high risk people, because the benefit for them is much higher than the risk. So that's why we have this shared decision making. We kind of talk about the pros and cons together and come up with a solution. We have to provide counseling, so we have to tell you why it's important to stop smoking. And every time I see you in the lung cancer screening program, we talk about smoking cessation. And I documented in the chart that I've actually talked to you about smoking cessation. And then we talk about compliance counseling. Compliance counseling, what that means is, if I find something that's abnormal, what are we going to do about it? And are you willing to take that next step? So if I say we're going to need to do a biopsy, are you going to go forward with the biopsy? Because to find something and then do nothing about it doesn't help you. So we always talk about whether or not if we find something, what are we going to do about it, and are you willing to move forward? If you say I'm not willing to move forward, then we say, okay, well, we're not going to put you at risk if we're not going to do anything about it. All right. Oops, I'm missing part of my slide. Oh, that's a little disturbing. Okay, well, there was a beautiful drawing down here. I apologize that you cannot see it. It's sort of like a balance beam, and it talks about who benefits from lung cancer screening and who does not. So the National Lung Cancer Screening Trial, what it showed is in people that were high risk, so those people 55 to 77, the people that had smoked at least a pack a day for 30 years, and had quit less than 15 years ago, those people actually had a 20% reduction in lung cancer deaths. Not all deaths, but deaths related directly to lung cancer. The hard part is that there's a range, right? So there's people that are really on the low end. So the more you smoke, the closer the fact that you're still smoking, the older you are, that risk can go as high as, or that benefit probably can go as high as 20%. On the people that are just barely making the mark, it's as low as 2%. The hard part is that was the patient that was picked. Those were considered the high risk people. But we don't know what to do with all those other people that have other risk factors, people that have been exposed to asbestos, people that have actually had other cancers, people that have had radiation exposure, people that have twins. I mean, one of the best questions I was asked is, I have an identical twin. I quit smoking before they did. She got a really nasty cancer. What should I do? Now, the trick is I have to be 90% compliant. So it means I have to follow the rules in 90% of the time. But I get to be the one that gets to be the rule breaker. So when I see somebody who I really think is at high risk, I'll break the rules and put somebody into the screening program, even if they don't really quite meet the criteria. But that's actually because it's a calculated risk, and I think to myself, that person's really at high risk. So these are the risks and benefits. So this table is a table that I created that actually kind of balances things out, and these are the things that we talk about. So I talk about the ability to detect a cancer early, but on the other side, a lot of people have a lot of nodules. The only way the lung has to heal after an injury, whether that's pneumonia, whatever, is to form a little scar. I don't want to be taking scars out. I only want to be taking cancers out and sending somebody down a pathway of surgery, whatever. And so there's that balance. And what are you going to do once we find that nodule? Is it going to be extremely stressful for you? It's very stressful. People get very concerned about, I have this nodule, what am I going to do about it? And so we talk about the anxiety of the nodules as well. We talk about the pros and cons, and are you going to have more risk with the radiation than you're going to get benefit out of this? And then you're going to have a lot of waiting time, and you're going to end up getting more scans. And the other thing is like I said before, nothing comes for free. So, when we do go down a pathway of trying to biopsy these things, every biopsy that we do comes at risks. And so we have to talk about all of those things. And so, like I said, it's a balance. We want to take out all the cancers, and we don't want to take any out that aren't real cancers. So we try to figure this out and try to balance and figure out what your risk is. So with respect to nodules, it's interesting. So I was actually involved in the American College of Chest Physicians guidelines for the management of lung cancer. And when we think about nodules, one of the big things is actually getting patients involved in that decision making. So it's actually thinking about, does this person need a biopsy? Does this person not need a biopsy? Because some things, if you think about it, if you really think that somebody's got lung cancer, positive that they have lung cancer and they have a nodule, you could say, well, why aren't you going to biopsy me, Dr. Michaud? And I will say, the reason I don't want to send a biopsy is because if I put a needle in it, if I take a pair of pincher forceps and I biopsy it, and it tells me it's cancer, and that's all you have, then I'm going to tell you, you need to have that thing taken out. But if I biopsy it and it doesn't tell me that it's cancer, but it doesn't tell me what it is, I'm not going to be happy. If you're really at risk and I really think this is a cancer, and I think that biopsying it's not going to help me with my decision making, then I put you through a procedure that you're not going to benefit from. So it's all about having that open discussion and talking about the risks and the benefits and what are the likelihoods that this actually represents a cancer. Now, we got some fancy tools in my world. So I actually get to play with all kinds of toys. And I once gave a talk about 10 years ago, which was Interventional Pulmonary, all of the many toys that I get to call work. So we actually are at the height of technology. We do all kinds of interesting things. And one of the things that we can do is we can use what's called radial ultrasound. So this is a lesion that we see on the little nodule that we see on a CT scan. And then what we do is we put an ultrasound probe, just like what you get when you get an abdominal ultrasound. We put it through our scope. We drive it out to the area, and we can do some fancy things, and we can look at it, and we can look at it through fluoroscopy here, and we can see that either we are in, and we can see whether or not we're inside this lesion. So see the shape of this? See the shape of this? They look pretty similar, huh? That's how I know I'm there. So I actually look on the ultrasound and say, oh, yep, there it is. And then I put my pinchers down, and I can actually take a biopsy of these nodules. This is called radial ultrasound. We also have some fancy-dancy technology, which is very much like the GPS of your car. So we take your CAT scan, we put it into a computer system, it gives us a roadmap, and it allows us to drive out to things that are far out in the lungs that aren't sitting right beside the airways. So it tells us turn left, turn right, go up, go down, and we go out to all of these really peripheral-looking things. These things are way out on the edge of the lung, because if you think about it, where I usually work is in the windpipe and the branches that sit really close to the center of your chest. But oftentimes, nodules sit way out right by the chest wall, by the edges of your chest. So to be able to get out there, what we do is we use these types of technologies. So we use this GPS technology to help us get out to it. And what we do is we target it. We put on the computer system saying, X marks the spot. This is where we'd like to get to. And it gives us the pathway. We drive out there. And then what we do is we put that little ultrasound probe in that I just showed you, and we show that we're in it, and then we take our biopsies. It actually really helps increase the reliability of our procedure and show that we're truly where we need to be. And what the data shows, is that when we actually look at all the fancy-dancy techniques that we can do to try and diagnose a lung cancer, and this is not staging of a lung cancer, it's just diagnosis, that in about 70% of the time, 70 to 80% of the time, we can get things that are even really right out by the edge of the lung. The things that really limit our ability to get there are just funny angles. So if it's going straight up here, you have to realize that these things are not super floppy. It's not like a piece of spaghetti. It's a little bit thicker than that. So sometimes it's hard to get places. And so we actually have a lot of reliability, and we can get to things pretty easily. The other thing that we can do with that fancy GPS technology is that we can actually tattoo lungs. And this is something that I do with Dr. Cerfolio. So what happens is when we have a nodule that's going to be kind of difficult to find at surgery, we help the surgeons find them. So what we do is we use that GPS technology to get out to the area. We put that little ultrasound probe in. We show that we're there. And then we inject a fluorescing, it looks like bright green neon fluorescent chemical into the nodule. It kind of leaches out and it finds its way to the surface of the lung. And then when the surgeon goes in there, they see a bright green beacon and they know exactly where to go to take that nodule out. So we actually get to help them a lot. And this is actually just showing you here sorry, I'm trying to see from my slides to see where it is. See over here, this bluish stuff? That's actually some of the tracer that we put in. And then we see this is the piece of lung that came out, and you can still see some of that tracer, and that's where that nodule was. The other thing that we do is we do a lot of staging. So this is actually the breakdown from the SEER database. This is actually the database that looks at all lung cancers in the United States and actually gives us information through the CDC and the NIH to actually tell us about the breakdowns of lung cancers. So what we know is that most tumors are not actually at the early stages at diagnosis. So when we think about more than 50% of tumors at the time of diagnosis actually have disease outside of the chest. They have metastatic disease. Around 20-25% of patients will have advanced disease. So the way tumors like to spread, and particularly lung tumors, is they like to start in a space, they like to grow outwards first, and they like to grow into things. Then what happens is they get into the filtration system. So how your body gets rid of cells that die is they filter them out through the lymph glands. You know when you catch a cold and you get the swollen glands in your neck? Well, you have those same sort of glands in your chest, and those get swollen. And so when the cancer gets into those lymph glands, it's considered locally advanced. So that's this group right here. 15% actually are the patients that actually start off with very early stage disease. Now, I think this number is changing. And I think the reason that number's changing, and we will expect for it to continue to change, is that we still haven't seen the impact of lung cancer screening adoption across the country. So I think that hopefully that number will increase because the tumors that we are finding with lung cancer screening are earlier cancers. So hopefully. And then there's a percentage of people in this purple bar that are actually people that didn't have complete staging at the time of first being seen. So there's a lot of different ways that you can get to those lymph glands to know whether or not that tumor had actually spread to those lymph glands. And the way we tend to do it, there's the old-fashioned way, which is called mediastinoscopy, which is actually they put a little incision in your neck, a little hole right at your just above your breastbone, and they sneak a scope underneath your breastbone and take samples of those lymph glands. Now, this is considered the gold standard. So this is what everything else is compared to. But I'm going to argue that this is fool's gold. And the reason I'm going to argue that it's fool's gold is because we go in through all the nasty things that we don't want to touch. And, I actually have a personal disclosure, which is my brother-in-law died from complications of a mediastinoscopy. So they don't come for free, and they say, oh, it's less than 1%. But you know what? When you're a patient or a patient's family, it's one or none. So either it happens to you or it doesn't. So I try to avoid this procedure if I at all can. And this year, or this time now, is the first time ever in history where we've actually said that if we do an endoscopic technique, so we go through your windpipe to get at those lymph nodes, or we go through your swallowing pipe to get to those lymph nodes, that we're as good as doing this gold standard. So we do very few mediastinoscopies. We used to do a lot of them here. And then I came and I ruined it. I've been here 3.5 years and our numbers have dropped down dramatically. And it's because actually we're getting really good data by using telescopes through the windpipe, looking at the airways, looking through the airway walls with ultrasound. And we can see the lymph glands that are seated around the airways. And we can put a needle into them and sample them without having to actually go underneath your breastbone and do a major surgery. We can do the same thing via the esophagus, the swallowing tube. So we can get to different lymph nodes. And so we do often a combination of the two. So we work very, very closely. My group works very closely with the gastroenterologist. So we go in via the airway first. We sample all the lymph glands that sit near the airways. And then they go in through the esophagus and hit all the other ones that we can't reach. Between those two, we can actually hit just about every lymph gland that could be affected by a lung cancer that is actually within the chest itself. So we also play a big role. My group plays a really big role in palliation. And this is actually the reason that I got into the field that I got into. And I will tell you honestly, watching somebody have difficulty breathing because of their lung cancer, or because of complications of their lung cancer, the look on a person's face when they can't breathe it's the terror in somebody's face is something that you see once and you never forget. And so that's how I got into this field, is that I was a young trainee. I saw somebody suffering. They were hemorrhaging from their airways from a tumor that was inside their airways. And I just stood there and couldn't do anything about it. And so I was actually a really early trainee. Although you look at me and you think that I don't look that old, I'm actually the most senior woman in the entire country for what I do. And so I was the first one in. And this was long before this area was even a field. And it all went back to that one patient. And so I trained in Europe because there were no training programs in Canada when I went through. And I'm originally from Canada and came to the US 11 years ago, fully trained and actually with having already previously worked in this field. One of the things that we know is that when we start looking at the palliative side of things, we know that we really improve patients' quality of life when we actually intervene on people. But we're really cautious because intervening means that we have something that we can do. So intervening means we're bridging to something. We're trying to help somebody get rid of those symptoms so they can continue to live and to live a for whatever length of time, the best possible quality of life. You know, shortness of breath, bleeding from your airways, coughing, having pain, those things actually really negatively impact the quality of life of patients that have lung cancers. And so that's really what we work on. Now, one of the things that is sort of my golden rule, this is actually a CT scan from a patient that I had in my very first year in practice about 20 years ago. And what it shows is that this probably means nothing to any of you guys, but what it means to me as a lung doctor is that I see in this one single CT scan, I see fluid around the lung, I see lung nodules, I see emphysema, I see scar tissue, I see all kinds of things. I see a blood clot in this one patient. This patient had every single possible reason to be short of breath with a lung cancer of any patient I've ever seen. And so this reminds me that when we're thinking about patients, we always have to balance the risk and the benefits and figure out, before I intervene on anything, before I do any procedure on any patient, I always think, have I ruled out all the other things that are really easily fixable without putting somebody under anesthesia, without poking, prodding them, whatever. So have I fixed everything medically that I can possibly fix as a lung doctor first? And that is my golden rule. And this is just sort of the same thing. This is actually all of my inhalers. I'm a lung doctor. We give everybody inhalers. This is a picture that reminds me of a couple of things. One, it reminds me of never open your mouth in a public forum. And the reason that reminds me of this is that when I was a first year attending, I decided that I was going to do something alongside being a doctor because, you know, if you're just a lung doctor, like, you know, you have so much spare time, right? So I took a photography class, and I was in photography class, and my pager went off. So I walked out of the room because I happened to be on call. I walked out of the room. I took my call. I walked back in. And on the break, I apologized to my teacher and said, I'm really sorry that I walked out. I had an emergency at the hospital. I had to address it. And he says, oh, well, what do you do at the hospital? And I said, well, I'm one of the lung doctors. And he said, oh, have you ever heard of the vital signs? And I was like, yeah, that's a throwaway magazine made by the health system. I have a very strict policy in my office that all junk mail must go directly to the trash can and never make it to my box. And he said, well, I'm the editor. And he goes, and guess what? We do profiles on physicians from the health network. And by the way, you're going to be Miss January. And I was like, oh. So this man literally followed me around for 2 weeks, took pictures of all of my patients, took pictures of all kinds of things. And then all of my colleagues very quickly made fun of me for months on end, going, ha, 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 we saw your profile. So this is actually a tunnel pleural catheter. And this is sort of one of the things that I'm kind of notorious for. And the reason I'm sort of notorious is that I was a really early adopter of this procedure. And what it is, it's, you know, one of the things that can happen is that the lining of the lung, so you have a lining on the lung and a lining on the chest wall. And those two linings can get injured from lung cancer. It can also get injured from radiation treatments and from other things with cancer as well. But the most common is that the lining, that there's little bits of tumor that make it to that lining, the tumor cells are shed into the space between the lung and the chest cavity, and fluid goes along with it. The only way that lining has to complain when it's irritated and angry is to weep fluid into that space. So that's what happens. So you get this big pocket of fluid that's sitting around the lung. And what it does, because the chest is very fixed, you can't increase the size of somebody's chest. So what happens is the lung gets pushed down from the outside. And so you start to breathe with a lot of difficulty. So I'm a plumber, so I actually go in there and get the fluid out. So many of you, or some of you, may have seen me because you had fluid around your lung, and I was the person that siphoned off the fluid. This is a longer-term solution. It's called a tunneled catheter. It's a little catheter that goes under the skin and into the chest, because once that injury is there, the fluid has a tendency to keep coming back. And with each time that it comes back, the lung gets pushed down and the breathing becomes a problem. So this is a good way to be able to actually kind of act a bit like a sump pump. One of my patients explained to me, like in my early years, and I've always used that term because I think it makes a lot of sense. So 3 times a week, a nurse comes to your house. There's a one-way valve, so nothing can go in, but the fluid can come out. So we open it up, we siphon off the fluid 3 times a week, the lung stays inflated, and the patients breathe better. The reason I'm infamous for this is because the very first big study that was ever done on this technology was actually done by me and my partner way back when. And there's a lot of funny things about it. So why do we drain people 3 times a week, people might ask? And the reason is really bad. And the reason is that I used to work in Canada, and we had a very fixed budget to take care of all the patients that had fluid around their lungs, which was like pittance. It was no money at all. So what we did is we figured out, on average, how many people did this affect a year. And then we figured out we gave all the supplies away, so it came out of our budget. So we figured out if we have to deal with this many patients, they need to be drained. How many times can we afford to drain them a week and still stay in our budget? And so it turned out to be 3. So, and this is actually stuck. And I have no idea how it's stuck, but it is stuck. This has been the rule across North America and around the world since then, and it's based on math. And now it's here. Now it's the law. So there's also some interesting stuff that we're doing here at NYU. So thoracoscopy is where we put a camera into the space around the lung, and we can look at that lining. And the big advantage to this is that when we look at that lining, we can find areas of disease. And so when we're taking the fluid out or wanting to manage the fluid accumulating, we at the same time can sneak with a tiny little hole just this big into the chest. We can stick this telescope in and take biopsies of that lining. And those biopsies are incredibly important because one of the things that's happened over time is that we are doing a lot more research on patients with lung cancer. We've come up with a lot of new treatments. When I started out in lung cancer work 20 years ago, it was kind of like a death sentence. And it was like, you get chemotherapy, you're probably not going to benefit from it, and that's it. And we kind of accepted that because we didn't have any options. In the last 10 years, we developed targeted therapies, so we did all these molecular analyses. In the last 5 years, we developed immunotherapy. It is a whole different world. And to be honest with you, I don't even know what to tell my patients anymore about what to expect. And the reason is that all of these lovely graphs about like how long are you going to survive, how you're not going to survive, all that, it's based on stuff that was done a long time ago when the treatment was really different. So I always have a hard time telling people when they say, so doc, how long am I going to live? Because that's, as soon as I tell them they have lung cancer, that's the first question that comes out of most people's mouths. Or the patient goes out of the room and the family member asks me. And I'm honest. And I said, listen, I'm not trying to sell you a bill of goods. I'm telling you the truth. I don't know. Studies are based on thousands of people, and we never know if you're number 1 or number 1,000. The other thing is that happens, which is really interesting, is that even though you get initial upfront tumor profiling, and they profile your tumor from A to Z, what can happen is your tumor can change over time. And that lining is an incredible source of tissue because we can go directly to where the tissue is, we see it, and we can peel away that piece of lining, and we send it to the lab, and they can do all kinds of molecular tests that can actually impact on your care. It can help the medical oncologist know what their next treatment option is going to be. And it's interesting because despite the fact that this seems so intuitively obvious, because it's a twofer, we get rid of the fluid problem, and also we actually get a lot of tissue that can help guide your treatment. the thing is nobody's doing this, or very few people are doing this. And so we started doing this as a sort of twofer package when I came here 3 years ago. And we have a very, very large series. And one of the interesting things is that when we do take those biopsies and strip that lining away, what it does is it actually makes the fluid seal, the space seal up. And when the space seals up, no more fluid can come, and you get rid of the problem. And that little catheter can just come right back out, which is really nice. It's a nice option for patients. And so we do a lot of these thoracoscopies. But I told you that nothing comes for free. And we always think about who's a good candidate to do something in their lining, in their space, and who's not. So, if somebody's got shortness of breath or has symptoms, but it's not the fluid that's causing it, then we should leave well enough alone. And there was a study that my group did several years ago that looked at if you have a little bit of fluid around your lung, but you're not having symptoms, do we need to do anything? And the answer actually came back as no. If it's a small little pocket of fluid and it's causing no harm, it's not causing you any symptoms, it's not getting bigger, then actually you don't benefit from as a patient for having that touched. So we don't touch those. If you actually have had a line of therapy or sorry, let me take a step back. If you haven't had any treatment yet and you have certain types of cancer that are really going to respond very quickly to treatment, we don't touch those. We'll drain it once, but we're not going to put anything in your chest. We're not going to put a telescope in there. We're not going to do any of that kind of stuff because that fluid's going to go away. And I don't want to do anything that's invasive to somebody that doesn't need it. I'm not going to put a hole in somebody's chest for no reason. That's crazy. So I wouldn't want it done to me. So I'm not going to do anything to you guys that I wouldn't want done to me. Sometimes we intervene because we need to actually get that piece of tissue, either because it tells us the stage of cancer at the beginning or because it helps us restage or it helps us drive treatment. So sometimes we do procedures for that, and that's a good reason. If sometimes what happens in the space around the lung is that it can be fairly big. It can be a big space, and you can put the big 2-liter things of Coke, the big bottles of Coke. You can put like 2 or 3 of those into your chest, believe it or not. You can fit that. Oh yeah, see? But if it's all one big bottle, one big space, that's easy to manage. But sometimes what happens is as we do things to you, and one of the reasons that we don't just do something called thoracentesis, put a little needle in there, siphon off the fluid like recurrently, the reason we don't do that is because every single time there's a little band of tissue that goes from the lung to the chest cavity, and that causes the space to get what we call loculated. It becomes somewhat like a bunch of grapes. You know how grapes have the peel around each grape, and you have this big bunch of grapes? Well, you can have as much fluid in a big bunch of grapes as you can in that soda bottle, but because it's in those little tiny sacks, it's really hard to get the juice out of them. You have to puncture each one of them. Well, the same thing can happen in the chest. So it can either be that big full space, or it can be little teeny tiny spaces. And when it's in those little teeny tiny spaces, me going into your chest and messing around does not help because I can empty that one little pocket, but I'm not really going to get very far. And the other thing is that if you're really at the end stages of your life, I think that the kindest thing that we can do for somebody, if they're really truly at the end stages of life, they're going to live less than the few weeks, then I think that intervening and doing something that's really invasive is just a cruel thing. And that's another reason that we wouldn't intervene on somebody. We also do a lot of interesting stuff in the airways. So in about a third of lung cancer patients, tumor actually, the very first manifestation of tumor, so the first time we know about it is because somebody either gets really short of breath because there's a tumor that's invading the airway and blocking the airways, or alternatively, that tumor starts to bleed. And like I said, my very first patient was a bleeding patient, and it was because there was tumor in the airways. So this is a little drawing, a sketch that I made on a computer many years ago, which these lines here, these train tracks, those are your windpipe. And this pink stuff in the middle is actually tumor. So what we have a tendency to do, we do something that I like to call medical sword swallowing. So we take a hollow metal tube, we go into your airway, we put you on a breathing machine, we breathe for you. And what we do is we go in and we see the tumor, we burn it so it doesn't bleed, and then we do something that's almost like coring an apple, and we core the tumor out of the airway. We get rid of it. We send it all off to the pathologist, And then we go back in and we burn the bottom of it, the base of it, so that it doesn't bleed anymore. And we get a lot of mileage out of doing that. And sometimes we even cover it up with a stent to hold that airway open so that people don't get into trouble again with bleeding or obstruction. So blockage or bleeding. And again, why would we do this? So, if your symptoms are either because of bleeding or because actually of blockage, so if you're short of breath, we've ruled out everything else, we've treated everything else, and you're still having symptoms, that's a good reason. If you don't have a diagnosis yet and you have a big blockage, or if you need some staging and we need to know what the stage of the cancer is, this is a really good way to do it. I used to always say, and I probably should change the slide, I say if there's evidence of blood flow beyond it. So that means that if we see that sometimes if the lung is down for a really long time, it doesn't re-expand very well. So if it takes a really long time for you to come to medical attention because that lung's been deflated for a really long time by that blockage, because you can imagine if you have something that looks like the shape of a Y and you cut off one of the limbs, there's no air getting to that lung, so that lung deflates. If the lung deflates for a long time, it gets kind of stiff and it's hard to open back up. And this sort of blood flow thing is actually a way for us to tell whether or not the lung has been down for a long time. Except I got fooled recently. And so about a year ago, I had a patient that actually had their lung down for 14 years. 14 years. And I thought, there's no possible way I'm getting this thing open. I did take what was in the airway out, and the lung reinflated. And so now I have to rethink my mantra of this never happens, because it does happen sometimes. Generally, if the lung is down for more than 30 days, so the lung has been deflated and we have multiple x-rays showing that the lung's been deflated for a long time, it's hard to get the lung open. But sometimes we can. And you know what? The other thing is we don't like to intervene, again, if I know that I'm going to give you some immunotherapy, or I'm going to give you some radiation, or I'm going to give you some chemotherapy, especially with small cell, and that tumor is going to shrink right away. I don't want to do anything, put a piece of plastic in there, do anything that's going to cause you to cough or whatever, because you have something that's in your airway that your body's telling you doesn't need to be there. So we don't intervene if we think that you actually have a really good chance of responding very quickly to treatment. So the take-home messages are that a third of patients present with central airway obstruction, and an airway intervention may actually improve your quality of life. 50% of patients with lung cancer will develop fluid around their lungs at some point in their treatment and may need an intervention. So may need one of those little tunnel catheters, or may need that telescope. And it's okay. It's a day procedure. Before I came here, patients would spend 3 days in hospital every time they actually had fluid around their lungs, and they'd have to be transferred from the cancer center over to the hospital to have interventions. We now actually do a lot of stuff in the office over at the cancer center, and those that do need to come to hospital, we do a little intervention in the cancer center, and then we arrange as outpatients to have you come in. We take care of your fluid in the operating room, and you're here at the hospital for a grand total of 3 hours, which is a huge change from 3 days. The tunnel pleural catheters and the pleuroscopy lead to really good successes at controlling your shortness of breath, and it keeps the fluid at bay. When we think about the multidisciplinary approach, having a lung cancer person or having a lung doctor on your team really does change your quality of life. So for each individual patient, it has a huge impact having that 10 brains are better than one phenomenon. The other thing that we know is that patients with lung cancer do better and are better able to tolerate treatment if we can control the symptoms. So unblocking those airways, taking that fluid out, it really does lead to better outcomes. You tolerate more radiation, you tolerate chemotherapy better, we can do a better job of treating you. The other thing that we know is that if you go to a high-volume center and you get your care at some place like NYU, where we see a lot of patients, where you have a very big experience, the patients do better. So that's the other big reason to not go to, I don't know. I'm going to throw this out. This is really terrible. I apologize, but I'm going to do it anyway. I live in Westchester. If you go to White Plains Hospital, just going to say. And You know, the other thing I'm going to say is that for lung cancer patients, having a lung doctor on your team that can actually help guide you from start to finish is actually really important. You know, I tell my patients all the time, after I do their bronchoscopy and I do their diagnosis, they say, okay, see ya, doc. I'm like, oh, no. You have a lung doctor for life. So which means that when you come back with cough from your radiation, when you come back because all of a sudden now you have fluid around your lung or whatever, you don't have to find a new doctor. You already have a doctor. And the other thing is that we work really closely. I mean, our offices, I don't know, for all of you who've actually been to the cancer center on the 8th floor, you'll see that like we're all lined up. And we go between our offices. So I go over to Dr. Shishua's office. I go to Dr. Sabari's office. I just walk in there and say, hey, can we talk about this? The surgeons are right on the other side of the hallway. It allows us to actually do right immediately with you there to ever have those conversations and figure out who's the best person to manage what and how do we work best together. And it's all for you. The other big advantage is that you sit in your exam room and you don't have to go all over the place. The biggest place you have to go is downstairs to radiation because the radiation docs don't come up to us, but that's the only member of the team that doesn't come up to us and doesn't come up to you. But so I think having that at all phases is really important. And this is my final slide, and I will say great cancer care is all about having the right team. And the reason for leaving you on this note is that these are my daughters. These are my twin 6-year-olds. And I will tell you, any person who's one of my patients has probably seen photographs of them because this year I had a little bout with cancer. And so these were my 2 cheerleaders. They were the people that made me helped me through chemotherapy, radiation, surgeries. So when I come to you and tell you I really want to try and help you, I tell you because I've actually been in your shoes. So this is my team. This is Elise and this is Chloe.